So let me talk to you about an issue that may be moot by the time this shows up on the web. What do you do while you're waiting for, if you're one of these patients who says, I really want to wait and avoid chemo and I want to try one of these new medications, but they're not approved now, but I need treatment now. And we don't know when they'll be approved. We don't know that they'll be approved soon, and we think they will be. How are you handling those patients?
I think that for a patient who needs treatment, you try to do good treatment whenever treatment you have available. I'm spoiled because I have many of these drugs in clinical trials, so in my practice it's less of an issue, but frequently, I can imagine if you don't have access, you have to ask yourself the question, am I going to travel? Am I going to go on something that's less well validated, maybe a trial of a drug that's coming along? Or do I just, look into what therapy might be appropriate for me as if these drugs don't exist? Because until they are available on a prescription pad, they're not available outside of a clinical trial. So I think that that's a highly individual decision that for the elderly individual who doesn't like to drive outside of town is going to have a very different answer for that than the 45-year-old who's been through 3 lines of therapy.
Are there any particular trials you have open now or that you know that are open across the country that you would say these are ones to consider? I'm thinking about patients who need treatment, maybe you have high-risk disease.
So you could run through any of the major drugs and talk about their portfolio of studies. So let's start with iwCLL. So iwCLL has studies in relapsed and refractory disease, so patients who've already been treated. One of those studies was Rituxan alone, plus or minus iwCLL, and that study's fully accrued, and now we're just waiting for the results of it. So hopefully that will serve as the basis for the FDA approval. There's plenty of discussion about whether that's good or not. Ofatumumab, another CD20 antibody that isn't talked about as frequently, has a study where it's ofatumumab plus or minus CAL-101 or iwCLL. That study's open and available and accruing and closing soon. And then there's a very wonderful study of bendamustine Rituxan plus or minus iwCLL that still has plenty of room for accrual, and we do think, at least the impression is, that there's a great deal to which these drugs work very well together. So for a patient looking for a study, I think that that's a good study. And that's in the relapsed refractory setting. There will soon be frontline studies for fit patients of bendamustine Rituxan plus or minus iwCLL. There is, for older individuals, you could choose between Rituxan or chlorambucil, and half the patients will get iwCLL, half of them won't. And then for patients with 17p deleted, there's everybody gets the drug. It's Rituxan plus iwCLL. So everybody gets active therapy. There's no randomization. So that's iwCLL.
That's a lot.
That's a lot. Ibrutinib has done quite a bit as well. They're moving into frontline studies, so for patients who are needing therapy but haven't been treated before, there's actually treatment naive, yeah. A large number of studies that end up somewhat complicated. So there's FCR versus ibrutinib with Rituxan. There's there's another study of bendamustine Rituxan versus ibrutinib with Rituxan, so it's a 3-arm study. And some of these have geographic variations, so some of them are going to be overseas, some of them are going to be in the States. There will be a 17p deleted single-arm study. Now this was actually relapse refractory, and this one's fully accrued already, so those patients are already, that study opened and closed very quickly. There's probably a relapse refractory study that I'm missing with the ibrutinib, but we're anticipating potential approval very soon of that medication. So and they will probably be approved as a single agent, just as a pill, not in combination with anything else. So there will probably be some studies that begin to look at ibrutinib in combination with other drugs. I believe there's a bendamustine rituximab plus or minus ibrutinib study, but I can't say specifically where that is. The third drug that I think is maybe a little bit behind is ABT-199, also known as GDC-199.
Very potent.
Very potent drug. And that study, that drug had a couple setbacks and is just emerging from those, but a very effective drug for which the main problem is perhaps high levels of efficacy that need to be.
Tumor lysis syndrome.
Tumor lysis syndrome.
Yeah. All right, let's pause there for a sec, and gave us a lot to think about there. Yeah.